Okay, right, thank you. So welcome to the Shropshire, Telford and Wrekin governing body meeting, which is being held in public. This is to, firstly, welcome all of those who are joining through the live streaming, and we're also recording the meeting for purposes of minute taking. Okay, so firstly, apologies. I've received apologies from Liz Noakes, and in addition to Liz, I know that Martin Allen has sent provisional apologies, which I believe we will take as well because of difficulty in connection from home today. So, and apart from that, Alison Smith may have to dip in and out due to unexpected family illness, and Rachel Robinson is kindly with us until 2 p.m. Okay, unless anybody's received any other formal apologies, we'll move on to declarations of interest. So the declarations of interest are published on the CCG website, on the Register of Interests. It's just really an opportunity for me to remind at this point that we do ensure that all our conflicts of interest are updated and that they are remaining relevant. I'm particularly aware, obviously, for clinicians that their roles may well frequently change during their tenure within the CCG, and that they're kept up to date as well. Mike, I see your hand raised.
Yes, you just need to update that I'm now attending the SCC, which is not on the Declaration of Interest.
Thank you, Mike. We'll note that. That's great. Just make some. Okay. Barry. Hello, Barry.
I declare an interest in Health Watch Telford and Wrekin and Dawley Town Council.
Thank you, Barry. Okay, we'll note that. Okay, so yes, welcome to all of you. I was going to start with the house rules for the meeting. The chat function is switched off, largely because it's the public who are viewing are unable to see the chat function. So it's far better that if we have questions arising, that we do that verbally rather than placing anything in the chat function. We aim to take a break in the meeting at halfway through, so at around 2 p.m. So that will give people a chance for a break. And without further ado, I shall hand over to Mark Brandreth for the Accountable Officers Report. Mark, welcome.
Thanks, John. An afternoon, everybody. I'll try and be brief. I can't believe it's 2 months since I started in post. The year is really whipping past. So just a few things to briefly update on today. The first thing is, of course, to apologise to our patients and our residents who are experiencing long waits for urgent care, particularly for ambulances across the county, and also in A&E. The local urgent care system is under extreme pressure. It's very difficult. We are working as hard as we really can, but it is absolutely fair to say, even working on a cross-organisational basis with all of our partners, things are really very difficult at the moment, and we're not necessarily providing the level of care that we would really aspire to. I make reference to the fact that that is right across the system. So whilst I'm obviously mentioning ambulances and A&E and the hospital, of course, it's right to say that also community services, social care, and also primary care, mental health services too, are really, really busy at the moment, as we both still continue to live with COVID and manage COVID. And I guess that really gives me an opportunity to mention a couple of things that patients and residents can do to really help us. The first is to make a plea, please, that if you haven't had your COVID vaccine, or you haven't had your booster and you're eligible for it, that you please do get it as soon as possible. It's a way of protecting you and your family, and of course a way of protecting others. This week we have two wards full of very sick COVID patients in our hospital. Now, thankfully, we don't have as many people in critical care as we did in previous parts of the pandemic, but nevertheless, for those people and their families, COVID is still with us. It is still circulating. It is still causing harm, and so that continues to put pressure on our system. So please do have your COVID vaccine if you're eligible for it. Also, quite rightly, that I say at the same time or near to it, if you haven't had your flu jab, that's also a very helpful and the right thing to do. I'm pleased to say I've had mine. So again, please do contact your local pharmacy, or your local practice will help you get your flu jab. Again, really important. This may be slightly less popular thing to say, but I am going to say it, which is that actually mask wearing is another thing that is really very, very important that people can do. So the old message of hands, face and space is still very, very relevant. We've seen very high prevalence rates in both Telford and Wrekin and Shropshire, and particularly circulation among school-age children, and then of course into their parents, and then of course into grandparents. And so again, just to emphasise the vaccine programme, but also regular lateral flow testing and wearing a mask in indoor settings where that's appropriate to do so. And I would encourage people to do that. And as I think as healthcare professionals, we try and set the right standard by that, and I think it's important that we do so. Alongside that, I want to thank my colleagues working in the NHS and in social care who are still working, wearing masks and protective equipment for many hours a day. It's not very comfortable, it's not very nice. We see you, we hear you, we're very grateful for what you're doing. This is going to be, as Amanda Pritchard said today, the Chief Executive of NHS, this is going to be a winter like no other, because we are trying to care for the usual issues, plus COVID, plus of course, we're desperately trying to protect patients that are part of our elective backlog and our cancer patients, so that we can get them seen quickly and appropriately. So huge amount of work going on right across the local health system on that. I also, just on the vaccine programme, want to say that we continue to do well on this. Particularly grateful to my colleagues in two parts, really, or three parts, I suppose. First of all, colleagues in primary care, GPs and others, but the wider primary healthcare team who continue to support the vaccine programme. That is making a huge difference, and we would be snookered without it. So again, thank you for what you're doing on that. Equally to colleagues in Shropcom who are now coordinating the programme for us with partners right across the system, and actually also to both of our local authorities who again are working really hard and helping us in an integrated way, including with schools and with care homes and others. So we should be proud of the vaccine programme we've developed locally, but we shouldn't underestimate its significance. I also, John, wanted to say three other quick things. So first of all, to say that a lot of work has gone into what's known as the SOC, the Strategic Outline Case for the Hospital Transformation Programme. So this is the next part of the documentation in terms of seeking approvals. It's very high level. I'm pleased to say that that's been submitted by Shrewsbury and Telford hospitals on behalf of the system to the region, and then we'll go through to a national review, we believe, hopefully before Christmas. So no more news on that for now, but we hope to hear more about that into the new year, and we will try and keep people updated on that as we go along. I also wanted to thank Shropcom for their kind invitation for me to speak at their annual general meeting. I was delighted to do so. It was a really interesting session, and thank you very much to them for that. And finally, three people things. The first of all, to thank my co-directors in the CCG who are fantastic and knackered, it's fair to say, working incredibly hard. I got that the right way around as well. Fantastic and knackered, working incredibly hard across a whole range of things. So I couldn't have been more impressed with you lot since I've arrived, and I wanted to say personally thank you to all of you for your unstinting support and for the hard work that you're doing. It is very much appreciated. On the back of that, I also wanted to thank Steve Trenchard for his hard work in particular. His time is coming to an end with us in the next week or so as he moves on to pastures new. Steve, we've enjoyed working with you, and we wish you every success in your future career. So thank you for that. And finally, John, to congratulate one of our staff. So you'll remember that we have a Star of the Month. So I'm really pleased to say that this month's Star of the Month, the winner of this month's Star of the Month is Angie Porter, who is fantastic and one of the team that's been working on our complaints work in particular. A really good egg was the way she was described, and we're very grateful to her for her hard work. So really well done to her. John, thank you. Back to you.
Wonderful. Thanks, Mark, and thank you for such a comprehensive and wide-ranging introduction. Were there any comments or questions for Mark on the basis of that introduction, particularly in terms of anything that may not be directly on today's agenda? Okay. And I would like to echo your thanks to Steve Trenchard as well, Mark. Excellent. Okay. So if we can move on to the minutes from the meeting of the 8th of September of this year. Rather than going page by page, if anybody has any corrections to make, any points of factual accuracy, then please, if you could raise your hands, we can address those individually. Steve James.
Hi, just a very quick one, John. I think I'm down as Mr. through most of the minutes rather than Doctor. Just not that it bothers me, but it's probably better for accuracy.
Yes, no, thank you, Steve. It's right on the attendees, but as you mentioned, it's within the report. Thank you. We'll have that corrected. And Lynn?
Just a small similar issue for me. I miss in the beginning and Mrs. and who knew that marriage could happen so quickly. But also 12.8, I think that paragraph just needs tidying up a bit. It's doesn't make a lot of sense.
12.8, let's just flip to that. So 12.8, this was Mark. What is needed? Mark recommended that the digital strategy.
12.7, sorry, it's the one that's about what I said.
7. Oh, yes, I was wondering whether
it's just a sentence that takes about 4 lines, and it doesn't make any sense.
Lynn, have you got a suggestion of how it should?
I can forward that if that's all right. Do you want me to just forward it?
That would be fine, and we can note the correction at our following meeting. That would be fine. Okay. Thanks, Lynn. Okay. So, notwithstanding those corrections and comments, any other issues with regards to the minutes? I don't see any other hands. So we'll therefore accept those as a true and accurate record of the meeting of the 8th of September 21 with those amendments awaited. Thank you. Okay. We move on to the action tracker now. And firstly, I'd like to just thank those that have worked on this action tracker. Sorry, Julie.
It's okay. It was to regard the first action. I just want to update the governing body. The update on neurology is going to SCC in November. The paper was shared yesterday.
Okay, lovely. Thanks, Julie. Yeah. So, and I was going to just thank those that have been preparing the action tracker. And I know all the execs become involved in this. It's really so much easier to use with updates such as this. So what I will do is just go through very briefly the various items on the action tracker, and we can pause at any questions arising from those individual points. And if you can put hands up as we get to those individual points, that would be really useful. So Julie's explained that regarding the first action, and that we recommend that be closed. We'll be going through to SCC. With regards to the second item, that pertains to the niche report, and I note that the comments there are that this will be that niche will be presented to the system quality group at a future meeting. Now, this was a report that was commissioned by the CCG, and I think Mike, I believe you have a question regarding this particular action.
Yeah, thank you, John. I remain slightly confused as to how this has been closed. I felt it was such a serious issue that I understood that there were a lot of difficulties about getting information to it. However, what I was concerned about is it says it's going to a system quality group at a future meeting. I don't think I remember us agreeing that this should be taken off the board. If that's the case, then I'm happy to stand back and apologise. But I felt that this should, if it was going to be moved somewhere, it should have been decided by the board, especially as we were still asking about various activities on it. The only thing I can think about shutting certain comments was more about the diabetes and stuff like this, rather than the whole thing completely. So I'm not fully happy that it is going to be just moved without any say-so from the board. I do feel that it needs some time limits or something on it to be reported back, and that it is far too woolly and far too fluffy for us to actually get to know what is going on. So therefore, I must admit, I'm happy for it to be moved to a clinic, but unfortunately, a committee rather than a clinic, but with due restrictions. If that makes sense.
It does, Mike. Thank you, Zena. This was commissioned by the CCG. I know that some of the work would be done at the system quality group level, but unless this item, as Mike says, really is, if the action is for it to be recommended to be closed, it does need to sit on an action tracker at some place within the system, and at least on the action tracker of the SQG. But I think the question there from Mike very clearly is there an opportunity here for the board to receive the conclusions of that work done at the system quality group, which is predominantly an executive level board, committee of the ICS, particularly as this was a CCG commissioned report.
Yeah. And I hear the discussion and Mike's points well made. So we are increasingly moving our quality governance to the system space, and a number of you will be aware of that. And with this being a system piece of work, albeit the CCG commissioned it, it was a collaborative piece of work that was undertaken with system partners. We felt this would be applicable to put it into the system to address the recommendations, and we have had that back to board. We've had the full report back. Where we're at now is wanting to get some progress on the actions to attend to the recommendations, and to be fair, that is where we have stalled, and we've actually stalled more recently still. So we thought we had a mechanism for that, but what we have found in the system is that partners around, and that is the providers and the CCG, have not been able to put the attention to this to land a full and comprehensive report back to this board at this meeting, and that we're in live discussions about how we remedy that and how we prioritise the main recommendations that we do need to press on with. And it's not an easy thing to define, really. So I hear Mike asking for some timelines on this, and I can't offer that today, but what I can say is that we are talking about this in the background, and that I would hope to bring an update to the January board. Happy to keep it on this action tracker and also dual run it with the system quality group action tracker there, and we can evidence that we have had discussions there.
Okay, and Mark.
Yeah, just to kind of support Zena's thinking, John, if I may, just so we get a simple resolution for this. So I agree with Mike. It was a piece of work commissioned here. There, of course, needs to be a link here, and Zena's not suggesting that there isn't. John, can I suggest that what we do is, I think, and I'll work with Zena on this to try and help her with the kind of, if we need a bit more, let's put it this way, if we need a bit more time from some of our partners to help us get that, why don't we do as Zena suggests, do a bit of work on that and report back clearly to the January board. My suggestion, John, would be if there are a couple of governing body members who on our behalf would be willing to be involved in perhaps a one-off meeting with me and Zena on that, perhaps in say 2 or 3 weeks, we could use that as part of the way of providing assurance through to the January board. So in other words, we don't just go quiet between now and January. Yeah. We kind of share our workings. So Mike, you know, I'm leaning on Mike. Mike may be willing to be involved in that, but perhaps if we take it outside of this, that a couple of governing body members meet with Zena and I just to refresh where we get to with that, and then we'll bring it back to the January board.
That sounds eminently sensible. Mike, there's an offer to you. We will keep it.
Happy to do it, Zena. Well, you may or may not know my email, but yeah, happy to help. I think it entirely understandable. I wasn't trying to say that we definitely had to do it, but I do feel that we do need to keep a close eye on it.
Yeah, I agree.
But, yes, I support it. But yeah, please involve me. That's cool.
Perfect.
Thank you.
Great. Thanks, Mike. We'll keep that one open on that basis. Lovely. Great. On to item 3. That's the work on the falls prevention. And the recommendation is that this will be scheduled for the December Quality and Performance Committee meeting. Therefore, at the present time, that remains open until we've had assurance that work has been presented there. Item 4, regarding delegation to the governing body committee structure to support development of the ICS. Alison Smith is working on that. And has indicated that she will flag any amendments required to us, so it's recommended that that action be closed. Item 5, regarding Mark feeding back through regarding this the staff feedback on the work of the CCG. Mark, I believe you're addressing that verbally today. Is the recommended action, and for it then to be closed. Item 6, this is regarding quality and performance, and the item here, the first stem of this was regarding concern regarding the quality of data that we receive through to quality and performance and the reliance on that. Zena, you've kindly indicated that this will be agended at appropriate time. There are further stems to this item which have recommendations to be closed with, but on that first aspect, do we have a time scale expected for that?
So, sorry, just in terms of the timeline, I think the data quality relates to the maternity services, and I think the LM&S would probably be the right route to be capturing those detailed discussions. So I think what I can bring is an update from the LM&S to this group to indicate how we are assured or less so on various elements. I mean, and you know, things have moved on since that item.
No, that's helpful, thank you. So if that comes back to us after discussion through LM&S, that would be excellent. And then the other stems on that item, the third stem is within the papers for today, which is regarding the winter plan. So we would recommend that be closed unless anyone felt otherwise. Okay, I'll by all means pop hands up as we go through each item. And then item 7, again, both recommended stems that this be closed. And we've got references within the finance reports today. Item 8, again, recommended that this be first stem to be closed. Julie's kindly circulated the report regarding that. And then with regards to outcomes and inequalities, that's been included within the quality and performance report so for today, so therefore again recommended be closed. And then items 9, 10 and 11, as explained within the comments section on the action tracker, all those are recommended to be closed, and item 10 in view of it being on today's agenda. Okay, good, thank you. Right, okay, so in terms of moving on to questions from members of the public, we have received questions from a member of the public, and these, together with the answers, shall be published on the CCG website within 21 days of today's meeting. Okay, thank you. So moving into the assurance reports, quality and performance. Julie and Zena, thank you for your work in preparing this. We can take it that these papers have been read, and I would propose that we really move fairly directly into the meat of the discussion and questions, really, if we may, to best use of time. And if there's anything that we don't capture within our discussion that you would like to add towards the end of that, then that would be really excellent. That would be welcome. Thank you. Okay, so looking to members of the governing body for comments and questions regarding the quality and performance report before us. Thank you, Rachel.
Thank you, Chair. So this was well, encompassing all of these performance questions, really, regarding patient flow. We understand that work has been done and is still ongoing regarding urgent care and interventions with the DOS to provide, the right outcomes to where the patient gets to. Small, tiny changes, but everything makes a difference. But doesn't really give us the answers for the back end and how patients come out and their disposition and why the waits are there. So it was really to understand the plans around what is going on regarding patient flow at the discharge end, and are we using the interventions to the best of our abilities, like the virtual wards, and particularly regarding COVID patients and COVID oximetry services that are used in other areas to help the movement of these patients out of SAF beds and into community or their homes. And it was just, are there any further work doing on that? Because until we get that patient put out, we can't really make those changes to improve, the movement through the system.
Thanks,
Should I take that, Josh? And then,
yeah, you that question.
Yeah, and Sam may want to add to this, but there is absolutely a huge amount of work being done on that back door. That we've got our system integrated discharge team that's working incredibly hard on this. Like everything else, though, Rachel, we do have our challenges. There are challenges with systems and processes and staffing and a high number of agency staff within the hospital. That means your discharge planning isn't as smooth as we would like it to be, and there's lots of work internally within the trust on that. When the patients are ready to discharge, we've got the ongoing pressures around domiciliary care and residential and nursing care. Again, we've got both local authorities working very hard on that. We're looking at initiatives to try and maximise things like the START scheme in Shropshire and the equivalent in Telford, again, to try and maximise our care capacity, because that is an issue. I would say with regard to virtual ward, you're absolutely right, and that is an area that our colleagues in the community trust are leading on that. And there is some work to take that forward, and that's hoped to be in place by the end of November. Martin Allen, I've been in touch with Martin, and he's offered to provide some support to that, and with particular emphasis on those COVID patients, because we know one of our biggest challenges at the moment is that increase, that significant increase to the numbers of patients in the hospital with COVID, more than twice the level that we'd planned for. As Mark said, thank goodness not on critical care, but still occupying a huge number of beds and requiring a huge amount of nursing and medical attention. So those are all the things that are happening. So yes, they are work in progress, but we are again working within the constraints of our care capacity and our workforce that I've articulated.
Thank you, Julie. Thank you. Rachel, I was just going to ask Mark at this point. Mark, were you looking to add to Julie's response there, or
yeah, would you mind if I just made a brief comment just about the strategy, really? So Julie's given a great answer and totally comprehensive, but just to give you the strategic framework, we've made quite a significant change in the last few weeks. So, and forgive the language here, you know, these are our loved ones that we're talking about, but I'll just stay with the kind of management vernacular. We've moved from a push model to a pull model. And what I mean by that is, rather than, and again, forgive it, rather than the hospital pushing in the nicest way, thoughtfully and carefully, pushing patients through and getting them out, the community services are actually going in and pulling patients out. And Rachel, you'll understand the significant difference in that, because what it means is actually the thresholds are different, because hospital-based staff and community-based staff have quite a different risk appetite. And for the uninitiated, what that often means is community staff are happier to take people than perhaps acute colleagues think they will be happy to take. So that is, the green shoots is the phrase I would use. That's really helping us. And that, it's all right, it's a terrible cough. That really comprehensive multidisciplinary team approach is actually working really well. So, John, I just thought it was worth calling out the strategy change on that. Second thing briefly is, I'm very pleased to say that we've managed to put some money in to support the domiciliary care work by basically using healthcare assistance through the community trust to support the domiciliary care market without destabilising it. We are, and the shorthand here is, we are able to recruit healthcare assistants. There is a significant shortage of domiciliary care staff at the moment. So really good example of creative system working, of trying to kind of support and move money around in the right kind of way. So again, another quite significant strategic change, John. So just thought for the board, just worth calling out those two things.
Excellent, thanks for that clarity, Mark. And Rachel, does that cover your questions?
Yeah, yes, it does, but on the same paper and probably linked to the same thing. I just wanted to query where you've listed the sort of individual areas like Robert Jones and you know, the mental health, and you've put West Midlands Ambulance Service with no exceptions to report. And obviously, I'm not saying that there is a direct quality issue, but there is quite clearly. Quite clearly a problem with emergency ambulance, as you alluded to, Mark, earlier on in the meeting, where we are waiting a considerable long amount of time for our 999 ambulances. So that to me is a risk issue for our local area, and I just wondered why that doesn't feature as a problem.
Perhaps I could answer on that. Yeah. Actually, it's
Thanks, Rachel.
Yeah, it's seeing it through a different lens, Rachel. So thank you for that. Sometimes it's helpful to just, you know, ask the question, isn't it? I think when we've constructed these reports, they've really been around the serious incidents and the issues and the quality issues that are coming our way. And but you're quite right that if, you know, we can't fail but to have quality and safety issue if we haven't got our ambulances out and about and attending to patients that need help. So perhaps not reflected so much in this report, and I will give some thought to that really, but it does link to the ambulance turnaround times and performance. So perhaps we ought to just pull out a little bit of narrative on that. It might be helpful to know we've got a set of standards that have been published now by NHS England around what we need to do as a provider, perhaps a SAF, to attend to patients that are on the back of an ambulance waiting to be offloaded. Now, we've received assurance from the Trust that they've implemented that, and that's a live process in their department. So in terms of patients actually waiting on the ambulances, we've had that assurance, and the CCG are supporting SAF to just test that out by doing a quality assurance visit, Rachel, so that we can see it live, so to speak. Notwithstanding, the situation has significantly ramped up in recent weeks, so it's not just on the back of an ambulance, it's in a corridor, it's whatever other areas are being cohorted. This really, you know, you'll appreciate is a significant issue that we're dealing with at the moment, but I will put some thought to it, so thank you for raising it.
Yeah, and also on that, it'd be interesting to know not only the ambulances that are called by the professional services, but the 999s, and how they what many they do convey, or how many they convert, for want of a better word, to a different service, or is it just all conveyance? I'm sure it isn't. Just so that we.
Yeah, I mean, all of that does get measured through the urgent care board. Yeah. So perhaps we just need to reflect it through that route.
Yeah.
Thank
you. Thanks.
Thanks very much. Thank you. Audrey.
Thank you very much, John. Good afternoon, everybody. Zine, probably for you and your team, this one, there's a further 2 SIs in maternity that we can see there, and the words are 2 further SIs that caused harm. Obviously, there's so much work going into maternity to improve its safety and quality. That's a 2-part question. How are we assured that this improvement is happening? And then these further 2 SIs, are they part of existing themes and trends, or are they new merging themes and trends?
Yeah, okay. So thank you, Audrey. So what the Trust has done is undertaken a bit of a look back exercise around they've started with maternity, but they will be undertaking it for other serious incidents, and it was work that we'd actually started ourselves as a CCG, and they're picking up on their part of that. They've had a couple of complaints that have come in around not just maternity, but sort of wider care, that's prompted them to do a look back. So not all of what we're seeing reported now pertains to the current period, but some of it does, Audrey. So without opening the incidents and checking through, I can't easily tell you that, but I know that has been the case. Very small numbers, 2 or 3, I think. I'm not anticipating any further retrospective ones will be reported, and I think it's healthy and right and proper that they're being transparent and sharing with us that they are now reporting a couple from in the past. One of the SIs I do know is it fulfills the criteria for referral for the Health Safety Investigatory Branch, HSIB, because the newborn required cooling, and that's an automatic. Once it's referred to HSIB, it's an automatic flagging as an SI. It doesn't mean there's a cause and effect. It means that it's an incident that warrants further investigation, and these are both being looked at in the investigatory process. What I can say is there's a very transparent process. They just call it RALIG, and it's a Review and Learning Improvement Group. It's a multidisciplinary group. It's executive led. The CCG are members around that group, and on a weekly basis we're there reviewing not only the incidents that have been reported, but those that are there for discussion about likelihood to be reported. So I think to be included in that is very transparent, and they just very much take on board what the CCG are saying there. To come back to your point around themes and trends, we're looking at that, Audrey, because there are inevitably some repeat themes and trends that will come up over any period of time for any service with any serious incident. So I provide a little bit more information probably in the next report, and happy to liaise with you separately actually, Audrey. I know that's a particular interest, and you know, anything that I can do to kind of help that understanding outside of this meeting, I'm happy to do.
Lovely, thanks very much, Zena, and it's great to hear there's 20 new midwives starting. That's very real success story. Thank you.
And what that is allowing the trust to do is to look to reopen their midwifery-led unit intrapartum care. They've maintained antenatal and postpartum care in each of their MLUs, but this allows the Wrekin MLU to open more consistently. We're not quite there yet, but we're definitely getting there.
That's really good news. Thank you.
Thank you, Audrey. Now I'm aware that a couple of others with questions, and I just wanted to, if there was anybody with any comments to add regarding the maternity aspect, are you able to hand up as well, so that I can see whether this particular, okay, no, that's fine. Zena, can I just add then in the maternity? I noticed that, you know, it mentioned regarding the staffing of the maternity units, and that, you know, with only one unit open at one point, still problems with understaffing. And I noticed that there's 20 new midwives that are hopefully joining the trust in the next few weeks within the report. Just any comment about the state of the staffing of maternity at the moment to add to that report?
I mean, nothing specific really, John, other than, you know, it's really positive that the trust has managed to attract such numbers of new midwives, especially given the spotlight and focus on maternity services in our system. And I think they've achieved that because of their commitment to supporting new midwives out of training and their preceptorship and development and support package, really. So that's very positive. They have supported their leadership structure, albeit by temporary means, but some of those temporary solutions have been really positive, and we've definitely noticed the benefit from having those folk in and supporting SAS. So that's been great, really. I'm confident on their risk assessment process for the requirement for closure. The CCG has worked very closely with SAF to be able to articulate that so that there's a shared understanding and agreed level of risk. That's really important, that it's not an unbalanced view, and that both sides would recognise that, and we're satisfied that they're keeping that under review and receive updates to them on a monthly basis. So they won't open it unless it's safe, and we understand the reasons for that.
Okay, thanks. Thank you, Zena. Just a little bit of background noise. If those not actively talking could just put to mute, that would be lovely. Excellent. Thank you, Zena. And I notice you, yes, in your response, you detailed that the risk associated with staffing levels is an actively being monitored. Just for assurance, is there any indication that serious incidents have occurred through staffing shortages at all?
So I don't think there's evidence of that, and if you refer to the detail in the report, it refers to staffing red flags. So there is a real clear assessment of level of acuity and dependency of the mums in labour and having delivered, etc., matched with the staffing assessment, and immediate measures are put in where those staffing levels are deemed to be unsatisfactory or unsafe. So I'm confident on that. And when we talk about red flags, it's the period of time where staffing is suboptimal, but it's not the entire period of time. So it's the number of occasions, and then those are attended to by drawing in non-clinical staff, for example, or changing arrangements. So on those particular shifts, there is really clear clinical leadership to look at the outcomes for mums and babies and the experience, and we're not seeing the serious incidents that are being reported, and bearing in mind it's 2 and the number of red flags runs to multiples this month, they're not correlated.
Thank you, Zena. Can I bring in Donna?
Thanks, John. Firstly, thank you for the report. There's a lot of information in there for us to look at, and I'm also conscious this first comment is quite generic. So I am conscious that there will have been a lot more detail potentially presented at the quality subcommittee, because that's what it's there to do in terms of scrutiny on all of these issues. But just in terms of for us at governing body, when we see it, I think there are occasions where it might be helpful to have some sort of assurance statements around some of these particular issues, because you've just given some good assurance around some of the maternity issues there, and I'm just thinking that might help us in relation to when we get this paper to review. So the assurance that the quality subcommittee has already given. And I think just in terms, John, and I know you're letting this discussion run on, which is, I think, wholly appropriate, but if we could look at the times that we allocate for this section of the governing body, because it is so critical to our system. So after that bit, one of the areas that sort of just came out, for which I'd like a little bit more sort of clarity or detail on, and I know this is a national issue, but again, it's sort of post-COVID, this low referral for potential lung cancer, and perhaps potentially linking that with the no access to walk-in X-ray. So I just wondered if there was somebody who could provide a little bit of further detail on that for me.
Julie, thank you.
Hi, Donna. Yes, I was actually, if nobody had asked the question, I was going to say, use the opportunity of our public board meeting to please put a call out there to any patients at all, please, showing any kind of lung or upper gastro intestinal symptoms, to please go to their GP. We are still seeing low levels of demand. We can't be sure that it's entirely linked to the walk-in X-ray. Obviously, we're still trying to manage that from an infection prevention and control perspective. But what we have done is, because we are concerned with that, the planned care recovery, we have taken that through the clinical leads route and escalated that through Jane Povey and the system clinical leads to try and put all of our concerted efforts on what we can do to try and affect that. We're also, all provider colleagues were reporting on their interpretation of the new infection control guidance last week. So we are waiting for the feedback of that and hoping to see any positive impact of that will have on capacity or removing booking restrictions that will help with that. But you're absolutely right to note it, Donna. And as I say, I would encourage any members of the public, it's still absolutely safe to access your GP and to come forward, because the sooner, particularly with the case of lung symptoms, the sooner those cases can be diagnosed, the sooner you start treatment, and the infinitely better the outcomes. So there's a real plea there.
Thank you, Julie. Thanks, Donna. Barry.
Mine's very quickly, Chair. Talking about the discharge problems and the challenges that we've got, they are quite a big challenge for everyone. Mark mentioned about the extra finance arranged for the domiciliary services, which is in dire need. I met with the Red Cross organiser for Shropshire yesterday in another meeting, and she's saying they're waiting, they are ready to help. Can we consider using the Red Cross hospital to home service and perhaps funding for them to help in the cause? That's to Mark.
I'm surprised, because we already do. And actually, there's a further paper going to our strategic commissioning committee again next week on that, but we do already have a contract with them and already provide funding for that. And the paper next week is to see if there's any options to go above and beyond that. So we're absolutely on that, Barry. Thank you.
Good to hear. That's probably what she was referring to. Thank you.
Great. Thanks, Barry. Excellent. And Meredith. Oh, sorry, Meredith.
Sorry.
Yeah.
Can you hear me, John?
We can.
Yeah. Thank you very much. Thanks, Zena and Julie, for both fantastic and no evidence of being knackered at all. Thank you very much for the very helpful report. Just a couple of things. So picking up on Rachel's comments, really questions around flow. I think it's fundamental, and clearly is an enormous amount of work. And Mark, you've been able to set it out clearly for us there, moving to a pool arrangement. So a couple of questions. One is, to what extent do we feel that our winter plan has supported the arrangements that are currently in place to cope with the tremendous pressure that's going through the system. So whether that plan is worth its salt. And secondly, so this is a bit of a prospective one really, with the government's decision to make vaccinations mandatory, what will that do you think, to capacity, particularly if we're moving to a pull approach? Are we automatically going to have a tremendous capacity problem stopping us from pulling? They won't be able to push or pull.
Okay.
Now, I realise that it's kind of hypothetical, but it'd be interesting to get your feeling on it.
John, do you want me to, should I kick off?
Indeed, I spotted Sam's hand as well. So either yourself or Sam, I suspect. But yes, Mark.
Yeah, I'll take the second question and then hand over to Sam for the winter plan. I will, though, say a word on it, of course. Meredith, I'm going to say we're fortunate, and I think that is true, but actually it's also been a lot of hard work. The uptake of COVID vaccinations from staff has been really very good and very high. The devil's in the detail a bit, because of course there are a relatively small number of people who are exempt due to other clinical conditions or particular circumstances. So I think it will be I'm guessing the target will be 100% of those who are able to have it. We're in a pretty reasonable position with that. We have seen a very small number of care staff look to move from care settings into the NHS because it was already mandated in care settings. So their time is coming, because if they have moved, they will now be required to have it, and I think that's right. So our honest answer is we're still doing the work. We don't think for us it's going to be material. If I was comparing it with some other systems not too far away from us, it's a much more significant problem than I think it is for us. However, still more to do, and I'm actually taking it differently. I'm taking it as an opportunity over the winter to have another set of conversations with a very targeted group of staff about the benefits of the vaccine. But as I say, our percentages have been very high. I'll hand over to Sam on the winter plan. Suffice to say that the winter plan is never something that's written and then put on a shelf. It's one of those, what do we say? People like me say this constantly evolving document, of course, but actually both the relationships and the thinking behind it are standing up quite well, and we're probably going above and beyond. But John, I'll hand over to Sam to specifically answer.
Sam.
Thank you. So yes, I mean, I think that's a really important starting point in terms of the plan being iterative. It's important that at some point we put down the pen and say, this is the picture that we're working with. So the plan aims to do that. As you'll see, it is hugely comprehensive. It tries to cover all the bases. I think what's important to say in terms of this year is we have endeavoured to do this planning much earlier. We've involved the whole system, so it's a system plan that's pulled in all the partner perspectives in terms of the challenges we're going to face. I think it's also important to note that we are starting from an entirely different position this winter than we might be ordinarily. So it will be more difficult, I think, to determine the level of impact of the things that we are doing in terms of that more and the dependencies between those that we're working with. So in particular, for instance, if the COVID position, our modelling that we've done, redone again, did not necessarily predict, as did the national and regional modelling, that we would see the recent spike that we have, and we've therefore had to react to that and adjust our services to accommodate those issues. So it is ever evolving. We have, I think, left no stone unturned in terms of the approach this winter. And as Mark said, we continue to evolve that as we go. So hopefully that answers your question and gives some assurance.
Thank you both. Yeah, lovely.
Great. Thanks very much. Mike.
Hi, I'm going to be Steve James for a second, because none of the paper discusses it, IT. And one of the things we discussed quite a bit at the previous meeting was things that could be used simply to try and help things. And one was about electronic prescribing, which is mentioned in the minutes. Has anybody actually had thoughts about how things like that might actually be able to be introduced, to be used to try and help or not?
Thank you, Mike. So at this point, before concluding, Julie and Zena, I offered you the chance to raise any things that we hadn't covered within the questioning that you would like to highlight to board. If you wish to take that opportunity now and also cover Mike's question within that, that would be great. Thank you.
Thanks, John. Just a couple of things. Mike, in terms of the prescribing, it is absolutely on the SAF agenda in terms of their move. As I say, unfortunately, they have got lots of other, shall we say, digital challenges, not least of which moving over their ED system, A&E and emergency department system that's due in December. So I think it's absolutely noted, and we know the benefits of that. It has to be timed in terms of the other pressures and priorities, is my understanding. But I just wanted to touch on, in terms of not only the winter plan from an urgent care perspective, but also to try and give some assurance regarding, clearly those winter pressures give almost have a double whammy then on our elective recovery. And I wanted to let colleagues know that we are doing all that we can to support SAF to maintain the highest urgent surgical priorities in cancer treatment, and we're looking to maintain those. But what we are doing system-wide, and particularly the CCG, is also maximising its use of the independent sector with the full support of NHS EI to help to target our long waits. So we're trying to free up our local capacity to focus on those clinically urgent and cancer patients, and then use the independent sector. Both we are fully utilising it within the area, but also on the periphery of the county, and seeking mutual aid further afield where we can. So I just wanted to update that also to provide some assurance that we are doing everything we can to maintain as much of the elective recovery, to focus on the patients that need it the most, even during these challenging emergency pressure times.
Thank you, Julie. And Zena.
Yeah, briefly, Chair, thank you. I just wanted to update the board that the most recent inspection, CQC inspection of SAF, the report, we expect to be published in the next week or so, and that covers the 4 areas that were inspected around maternity, urgent and emergency care, the medical specialty wards, and the end-of-life care. So it was just to let folk know that that's coming. There will of course be communications put out around the publication date.
Thanks, Zena. Yeah, thank you. I mean, that was a really comprehensive and I think a useful discussion around the quality and performance report. So thank you for all your input. We're running slightly over, and I'm going to suggest that we were due for a break at 2:10. So if we take the finance paper next, as planned, and we'll probably have a short break after that, and then bring the board assurance framework following the break. So the next paper on the finance, again, I think I'm going to take this. We have been distributed the finance papers. My suggestion, therefore, Claire, would be that if there are any questions arising from the board members, that we start at that point and then come back to you to highlight anything that you think we haven't teased out that you would like to highlight to us. Is that all right?
Yeah, happy with that. Thank you.
Thank you. Okay. Any questions or comments for Claire? Watching out for hands. Thank you.
I will, if nobody else has got a pennyworth. It reads nice and positively as being on track, and it all sounds very good. I just wonder whether it feels as good as it sounds, because I find finance papers blur my brain a little bit. And I wonder how much of the sort of increased uncertainty in future is unknown things that might happen, and how much of it is that it gets harder to deliver the financial improvements over time. The easiest things comes first and the harder ones come later. So a sort of sense of how concrete that positive note is would be nice.
Yeah, no problem at all. And I suppose it kind of links to what I would have said in my summary as well. So it's not very often in our CCG that I get to deliver what is quite a dull report, let's be honest, because all I'm saying is for the period that we're reporting, we've done what we said we'd do, but that in itself is to be celebrated. So on one hand, you've got the positive story, as you say, that, you know, we've delivered what we set out to do for the period. We're now looking at second half of the year and the planning for that. But yes, the reality is that that kind of masks the fact that it is really challenging in terms of that position, and particularly our underlying recurrent position that we're working so hard on. I think it's fair to say, and you're right, Adam, that set of low-hanging fruit that we've had is diminishing. So it gets harder as you move on to deliver some of the savings that we need to make. And certainly as we get into more of our conversations through Finance Committee and through the board about next year and beyond, that's where the more challenging conversations will be had. So I think for this year, we have got a huge job ahead just to land the H2 plan, deliver what we said we would. I'm not saying that that's an easy task at all, it's not. But we've equally got to balance our effort and energy on looking forward that bit further into the future, because we've got a long road ahead in terms of that overall financial recovery. So it's not without its risks. Does that help?
Thank you, Claire.
That works for me.
Yes, and along those lines, Claire, I mean, I guess I know this is this month 6 report, but and you've covered that slightly in your answer already, but it's currently with this acute, you know, the demand on acute delivery, you know, whether there's any potential impact on our elective recovery and, you know, the knock-on effect on our finances for the future through the delayed, you know, potentially delay in our elective recovery.
Yeah, I think it's the elective recovery position. I'm more worried about our ability to deliver the activity. We are talking to NHS England at the moment about the finances for that. And I think there's an avenue for it to be funded. So if we can do the work, then it will be funded. So that won't impact on our financial position, bottom line. And certainly as we burn through the list, we don't accrue or accumulate work for future years. So I think for me, the focus is very much on where we can secure that activity. And as Julie's already said, that's where we're trying to be creative. So where we know we've got pressures within the hospital, for example, that's where the independent sector can play a really important role, or out of area providers. So there's a lot of work to go into talking to patients as well about their choice in that. And whether they're able to travel to do that, but certainly a big piece of work that will pay lots of dividends, and sort of not on a recurrent basis, because we will return to an underlying position, but will avoid us having additional non-recurrent costs of that lump of backlog in future years.
Yeah, thanks, Claire. I mean, where I was sort of slightly leading to, in a sense, and you've answered that perfectly, is should this be a financial item that sits on the BAF? I mean, the BAF we discuss next, but you know, in terms of
yeah, so in the BAF we cover finance in its entirety, and in the context of our underlying position and the recovery programme, I would expect us to have separate items on there around the actual recovery itself. So I wouldn't lead the conversation about elective recovery from the finance perspective. I would lead it from the patient and quality perspective.
Great, thanks very much, Claire. That's grand. And Jeff.
Yeah, thank you. I suppose I just really wanted to add to what Claire was saying into response to Adam. I think it is a positive report in terms of hopefully it gives the board assurance that we're doing all we can to mitigate the risks and focus in the key areas. But I think I would probably draw the board's attention to point 30, which is we really haven't got any wriggle room on this plan. We haven't got any more plans to really deliver. So, you know, we are going into what's historically a very busy time of the year with emerging risks coming at us. So it may well look that that Claire is very serene and very calm on the exterior, but there's an awful lot of work going into this to try and get on top of some of those risks. So I'm probably less confident than maybe Adam articulated, because there's still a way to go through this year before we even get into next year.
Thank you, Jeff. And Donna.
Yeah, thank you. It's building slightly on what Jeff's just said in terms of the no wriggle room and the issue with some of those significant cost pressures not withstanding WMAS, given what we've been discussing so far with regard to pressure in the systems. I'm presuming that's kind of activity driven. Is that worst case, or could it get worse? And also, I think there was an unquantified cost pressure around phlebotomy. So again, is that sort of built in, or is it an issue that we'll see in coming forward in a future report?
Yeah, so I'll take them in reverse orders. Phlebotomy will be something that comes through in future reports, but part of the work that the team are doing at the moment is to look at how we offset some of those costs and mitigate those costs. So we can't really, or I haven't seen anything at the moment that tells me for sure what that looks like. So we want to make sure that we pull all of that information together in one go. WMAS is an interesting one. So in year, we won't see, or I'm not expecting to see any additional costs manifest. We've agreed a figure for the year this year. I'm more interested in the costs that are coming through in the presentation of the underlying recurrent position moving forward. At the moment, we're being presented with a range of costs, and we're pegging our modelling on the midpoint of the range, because we're working on the basis that, one, we need to do some more work on testing the activity levels to make sure that they will sustain in the way that they are at the moment. And two, we are challenging the Ambulance Trust and ourselves in how we work to look at ways of doing things differently, more efficiently, so that we would avoid cost, even if that activity did come through. So whilst we're using that mid-range number, that gives us a sort of sense of a most reasonable assumption whilst we work through that. At the moment, we are basing our future look on an assumption that at least for next year, there will still continue to be some level of non-recurrent support for ambulance services. Until we get planning guidance through and until we see what comes through in December, we won't know for sure, but certainly that's a view that's being supported by the regional team at the moment in terms of the planning. So it's not a cliff edge on the 1st of April. It's something we've got a bit of time to address through the Strategic Commissioner and with the ambulance services themselves.
Thank you.
Thanks, Claire. Thank you. Jeff, is that a historic hand, or did you wish to come back on that point?
No, it's a historic hand. Sorry, John.
Thanks. Thank you, Claire. And I offered you the opportunity, if there was anything that we hadn't picked out of your report that you particularly wish to highlight, then you have this opportunity.
I suppose no. I was going to say a small thing, but I don't mean it in that way at all, because it's actually a big deal. One of the things that we have achieved in H1 in the plan, and it's noted in the paper, is that we were ahead of plan on our efficiency programme. So we certainly aren't delivering as much as we need to. I am definitely, as with Jeff, concerned that there's not a lot left in the tank for next year and beyond. But just to acknowledge the hard work of the teams, particularly CHC and some of the guys in prescribing, because in spite of very difficult circumstances, they've delivered a good programme for the first half of the year.
Okay, thank you, Claire. Right, good, thank you. Well, look, we're asked to, as a governing body, to note the information contained in the report and the need to continue the focus effort on the delivery of the recurrent efficiency target in order to meet the requirements of the sustainability plan. So thank you. And before we break, I realised that I hadn't actually recognised the recommendations from the Quality and Performance Report, which that we were asked to note the content of the report and actions being taken to address the issues identified. Okay, thank you. So we're at 2:10. I propose we now have a 10-minute break, and if we can keep streaming, so that we don't lose anyone during the break. But if you wish to turn your cameras off, and we'll reconvene in 10 minutes' time. Thank you.
Sé que algún día volveré, el tiempo lo dirá, no dudes de mí, es complicado de entender si tú no estás ahí, no puede amanecer. Sé que algún día volveré, el tiempo lo dirá, no dudes de mí, es complicado de entender.
Board Assurance Framework. For those that were here just a couple of minutes ago, we've recognised that there's a page of the BAF that hasn't come through due to the difficulties of putting it within a PDF file. So that will be published and put onto the website so that it's available. And we're going to continue at this point, as we have with the other papers. If I can just start by asking whether any of the members have any specific questions within the BAF. This is clearly, as is written in the introduction, has been through the audit committee, and it is here for our information, but also to discuss. Okay, thank you, Jeff.
Yeah, it's not really a question, John. It's more of a comment. Alison and I were at the ICS audit committee yesterday, on Monday. And it's just really an observation that our BAF is clearly a piece of work that's been built over a period of time, looking at the strategic challenges of the CCG and the mitigation that the execs are taking against it. We will be working with the ICS over the next 4.5 months to try to bring the two BAFs together. But it's just really around the fact that actually it's the CCG's BAF that's being used as the example, really, to continue work on the ICS one.
Okay, thank you, Jeff. And Audrey.
Yeah, very quick question. It's a tremendously comprehensive document, so different from the last time we saw it. It's yeah, very, very good. Just a very quick question, and it mightn't be a fair question. Number 9 is around safeguarding. Can we say a few words on it, or if not, that's absolutely fine. I completely understand it because obviously the page is missing.
Thank you. I'm happy to talk to that one, Alison, if I may. Yes, please do. This is a newly articulated risk orderly, and it's come about because since lockdown, our activity around safeguarding concerns has escalated quite significantly, and indeed the amount of attention we're putting to looked after children has gone up as well. So what I was able to do was to up some of the quota of non-recurrently for my existing safeguarding team, so that risk is mitigated down. But if I can just explain, when it was first explained out to me and we assessed the level of risk, it was coming out as an extreme risk at the level of 20, which is very high, and the gaps in controls there were around the volume of rapid reviews, then attending to the safeguarding governance, and in both local authorities the number of subgroups has increased quite significantly, and the amount of meetings that the safeguarding team physically have to be at has increased. The high number of out of area children that are looked after that are placed in our county, we're the second highest in the country, and that creates a lot of work for our looked after child team. And the shortage nationally of the NHSCI commissioned tier 4 beds means that we're holding a lot of risk in our system for children that perhaps would require a different level of care if those facilities were available. One of the things we're particularly looking overseeing is the health assessments that other systems should be doing on our children, and our children placed in Staffordshire in particular are not receiving the health assessments that they should be doing in a timely way. So our team have to chase and follow all of that up. So that gives an idea of the burden and the volume, really. So the additional resources enabled me to put some folk to the gaps in assurance, and pretty much that's sorting the problem. The risk will be mitigated at the next iteration down to 16, and we'll review it then and see. But it's always quite a dynamic piece, really, I think, safeguarding, not least because we have to attend to the intercollegiate guidance on ratios of workforce, and we really did trim that down actually with our management of change to on an affordability basis, and then wanted to review it. And of course, post lockdown, we find that we're in a much different position than going into lockdown. So it's something that I've got under review.
Thanks, Ina. Great to hear. Thank you.
Thank you. And Claire.
Thanks, John. I just wanted to raise the issue around children and young people's mental health. That actually I think we need to highlight that in more detail on the BAF. It kind of links to the point that Zena was making around some of the Section 31 issues and some of our complex children. So we're going to put more detail into that for the next iteration of the document.
Okay, thanks, Claire. And we should be receiving this back in January, so that's helpful. Thank you. And Mike.
I would also just want to add that it's not just safeguarding in children that's been on the rise, especially there has been a lot more domestic violence and abuse going on, so it is across the age group rather than just children. I think that just needs to be reiterated. Thank you.
Thank you, Mike. So, Alison, was there anything you'd like to highlight in addition to the points that have been raised?
No, that's covered it. Thank you, John.
Thank you. So the governing body is recommended to review the BAF and consider any additional assurances, if any additional assurances are necessary, and that the risks to the strategic objectives are being properly managed. And we're also asked to accept assurance from the CCG Audit Committee that the principal risks of the CCG not achieving its strategic and operational priorities have been accurately identified and actions taken to manage them. Thank you. Okay, so moving on, the next item on the agenda is the integrated care system update. Mark, and I believe this is a verbal update. Over to you, thanks.
Yeah, thanks, John. I'll try and be brief, just give some bullet points of the kind of stuff that's been going on. You won't be surprised to know a very busy time for the development of the ICS. A few things then. So we had what we called our first annual general meeting on the 14th of October. It wasn't, of course, a statutory AGM because we aren't an organisation as an ICS yet, and we don't have accounts to publish, but we try to kind of follow the form really of sharing back with people. And there was, I think, over 125 people on the meeting, sharing back with people the progress of the ICS, particularly around the pledges in the last period. And also, John, you'll remember that we shared an infographic, so a kind of short film that quite nicely sets out over 6 or so minutes where the ICS has got up to in terms of its pledges. And Alison, through you, we'll see if we'll provide a link to for CCG board members if you've not seen that, so that you can see it. I think you might find it useful. I've also shared it with the wider CCG staff, who equally found it helpful to see the progress on the 10 pledges, so which was good. We are just kind of resetting our work around what we've called before the big 6 ticket items. I mean, it's really fundamentally the ICS, the delivery of the ICS strategy. We've been doing a piece of work which we talked about this morning at the Chief Exec's meeting, which just puts that in context in terms of the development of our wider thinking, and more to share with that. The reason we're telling you that is we're now going to have a delivery board that's going to meet monthly. I'm going to chair that, to really make sure that the operational boards, so the work we've got going, many of which my colleagues are involved in, and the delivery of those big 6 ticket items are really pulled together, so that we've kind of got a bit more cohesion around that, really. And I think that will really help us. Also, over the last kind of month or so, I met with the pharmacy leads for a really interesting conversation with them about the importance of pharmacy for the ICS going forward. And so I do quite a lot of these, but I just thought I'd offer it as an example of how different professional groups are coming together now in a more coherent way than they have before, and really reflecting on their contribution. I think all really good news for patients, I have to say, and that group were very impressive in terms of the kind of things that they were thinking about. We had, this sounds very dry, and it kind of was, but we had a readiness to operate meeting with colleagues from NHSE this morning. It's really a kind of huge checklist of things that need to be in place. You'll remember the due diligence process and the work that Alison led for the merger of the 2 CCGs. And we were reflecting this morning about, although that was, I'm sure, very painful for Alison, although I'm sure a career highlight at the same time, actually that work's been really helpful, because having done that a year ago, knowing the things that we need to do again, in effect, to set up the new organisation are really important. So that is one important part. I'm very grateful to Alison for her work on that. But there's also a lot of work at the moment going on around board makeup, constitution, and also particularly the what's called the ICP. So the development of the integrated care partnership with the local authorities, and more on that in the future. But that work continues. So an awful lot of kind of nuts and bolts work in terms of the setup of all of that. The other news, John, is that I decided not to pursue an application to be the Chief Executive of the ICS. So I'm with you through until the end of March. I'm delighted to do that. But I know that Neil would want me to pass on that he's working very hard with my support to secure a Chief Executive for the ICS. And I also think shortly we'll be in a position, I would imagine in the next couple of weeks, really, following some national approvals, to advertise for the non-executive side of the ICS, or the ICB, forgive me, as we now call it, the Integrated Care Board. So again, those appointments will be important in terms of the rhythm and the processes. Finally, and kind of important crossover reflection, really, we continue to work really hard with the CCG staff to help them understand and see how their work fits into the new world. I mean, it absolutely does. So we continue to kind of keep our staff dialogue open and supporting people with the change. So important that I kind of mention that as well. So John, I think they were the main things for this month, if you like, really. Alongside, finally, our system development plan that's also been submitted, which really wraps up and sets out how we're doing all of this. So lots of work going on. Hopefully that's helpful, but quite a lot of process stuff at the moment, really. Thank you.
That is helpful. And any comments or questions for Mark regarding the ICS and the update? Okay. Thank you, Mark, and thank you for your ongoing work in that area. That's much appreciated. Okay, so moving on then into the next item on the agenda, which is the Workforce Race Equality Standard, the RES. This was a paper that we had to postpone from a previous meeting because some of the data was falling into the wrong areas, and so the report is presented correctly today. And Lisa, I'm not sure if Lisa's joined the call for this.
No,
Alison,
she hasn't, John.
that's fine. Alison, again, I think we'll, as for the format of the earlier items on the agenda, if I just open this up initially to questions and discussion, and I guess if I can start with one of my own to begin with, noting what the governing body's asked to note from the RES. I understand that this is data that comes from the two CCGs that existed before we became a single organisation, and I noticed that within the second part of the recommendation, it's that some of the actions that are recommended here will overlap to when the CCG no longer exists post the end of March 22. And therefore there's a comment that we'll not have a full year in which to complete these. And I guess my question really is so what happens with that, and what then, how do we communicate? Is there a plan of communicating this and handing this over smoothly to the ICS so that it's not lost, really?
Yes, that's already happening actually, John. So Victoria Rankin, in her role as executive lead for people for the ICS, is already collating RES data from across all of the partners in our ICS, including the CCGs. So we'll be submitting that to her so that she's got that full comprehensive view of the data submitted for each organisation. I can't speak for Victoria, but I've assumed that that's on the basis that the statutory obligation to report against this for the ICS will continue, and that she is receiving the most up-to-date data from the CCG. So in effect, it doesn't form a part of the due diligence process as a specific action on that checklist, but actually we're already doing it, and Victoria's already collating that information. So this won't be lost. It will form part of the new ICS corporate memory.
Okay, thank you, Alison. No, that's helpful and good to know. Any other questions for Alison regarding the RES? Okay, I'm not seeing any hands, so it looks as though you've covered this. Alison, with that in mind, and obviously you've informed us fully, but with there being few questions on this, are there any particular areas you would wish to highlight to us as a governing body?
The only thing I was going to highlight was, obviously, I think the main issue that stands out, certainly for me, is the lack of diversity comparable from our board currently to our staff groups. And my comment around our ability to actually influence that is limited. There's nothing we can do about that because we're unlikely to have vacancies that we would be recruiting to over the next 4 months. It would be pointless given that we won't be in existence. But I think I just wanted to say that there is a very keen push nationally that the recruitment processes for the new ICB include a really strong emphasis on the need to have a diverse collection of people on that board, which I think is really welcomed. And I'm assuming that they are taking all of the submissions that have been made by all partner organisations across the country around RES over the last 2 years, and are looking at some of the risks that, as a CCG we've had, because we've had elected people on the board rather than recruited. So, that does stymie your ability to have a more diverse selection of people that represent both your population and your staff grouping. So I think that's really welcome. I just wanted to highlight that.
Great, thank you, Alison. Yeah, really key. Thank you. Mark, I don't know if you want any final comments on this.
No, just to say, when we did a session with Roger Klein that was incredibly powerful. And John, I think your sense around this, which is we mustn't allow this to drop. We are at there's a really important inflection moment here where we can make a step change in terms of our diversity by running our processes really well. And Alison set it out well. I mean, Neil is very, very minded on this, which is right. I think we need to see that, make sure that we are as diverse as the staff that we've got and the population that we serve. So I think Alison's covered it well. So please take my comfort that this is a top of the shop issue in terms of getting this right for us going forward. And this is the moment really to try and do that.
Great, thank you, Mark. So the governing body is asked to note that the data is submitted on behalf of NHS Shropshire CCG and NHS Telford and Wrekin CCG separately, as the data is drawn on the 31st of March 21 when the two CCGs were still in existence. Also, that the action plan sets out some key areas for focus. However, this will be limited by the fact that post-March 22, the CCG will no longer exist and therefore will not have a full year in which to complete these actions. And we've covered that, discussed it, and been reassured that this will be carried forward into the new organisation. Thank you very much. Thank you, Alison, for that. So, moving through the set of papers that follow are for information only, and any points to be raised by exception with the chairs of the committees or report authors outside the governing body meeting. And then into any other business of which I've not been notified of any other business for this meeting. The date and time of the next meeting is set as Wednesday, the 12th of January 2022, time to be confirmed. So the resolve is that we resolve that representatives of the press and other members of the public be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest, Section 1, Paragraph 2 of the Public Bodies Admission to Meetings Act 1960. Thank you all very much for your contributions, preparation and rich discussion. Thank you.